Massage therapists know better than anyone the healing benefits of bodywork are not just for a lucky few. Rather, massage is for every body. ABMP's Massage is for Everybody Week, celebrated July 19th through 25th, is part of a bigger year-long movement grounded in advocacy, awareness, and inclusion. Join ABMP in celebrating the powerful benefits of massage and the meaningful role you play in your community. Together, we're helping to expand access, support underserved populations, and elevate the profession with compassion and professionalism. Learn more at abmp.com/massage-week. Stop straining your hands and start getting your clients underfoot. At the Center for Barefoot Massage, we teach you to use gravity and physics to deliver effortless, deep myofascial work. Through our fasci-ashi approach of myofascial ashiatsu, barefoot mat work, and stretch therapy, you'll learn evidence-based techniques to resolve persistent pain. Worried about your size difference in relation to clients? Our innovative Ashi strap supports therapists of all builds to vary pressure with precision. The future of massage is afoot. Discover our upcoming CE classes at centerforbarefootmassage.com.
When I was a kid, as most kids do, I liked making funny faces. Some of them made my family laugh, but some of them, I remember, were not very popular with my parents. I would twerk my lips into a crooked line, push my eyebrows into a twisted mess, cross my eyes as hard as I could, and stick my tongue out. And both of my parents would offer me a stern warning. If I kept doing it, my face would freeze like that. I remember thinking, really? Like, would that really happen? And then I think some kid at school told some tale of a friend's sister's best friend whose face really did freeze like that. Clearly, this wasn't the truth. It was obviously just a way to get us to stop being weird in public. Faces don't freeze. But as I age and look back at this parenting tactic, I realized that while my mom might have been wrong about the face, she wasn't wrong about the mechanism. Because things do freeze. Not from a single held expression, but more from the slow accumulation of held positions. Patterns repeated often enough will train the tissues. In the same way that reps build strength at the gym, stagnation eventually becomes interpreted not as temporary, but as the new normal. And nowhere in the body is this more true, more literal, and more anatomically documented than the shoulder. I'm diving into frozen shoulder today, and it may be not as simple as a shoulder making a funny face and getting stuck there, but it is a condition with a fitting name and a heap of clinical lessons that go well beyond the joint itself. In my research for this episode, I learned a thing or two, like the term frozen shoulder was coined in 1934 by a Boston orthopedic surgeon named Ernest Codman. He used it to describe a gradual painful loss of shoulder range of motion that had no obvious cause, like no fracture, no dislocation, no tumor, just a shoulder that stopped working. And before Codman, a French surgeon named, I'm going to mess this up probably, Simon Emmanuel Duplay, in 1872 had described it as periarthritis, or inflammation around the joint. That label was closer to the actual mechanism, but it didn't stick. The clinical term we use today, adhesive capsulitis, was introduced in 1945 by Julius, and I'm going to mess this one up too, Neviaser. He is the one who finally went in and actually looked at the tissue, and what he found was exactly that, a capsule that was adhered. Capsulitis means inflammation of the capsule, specifically in the glenohumeral joint capsule, the fibrous sleeve that wraps around the ball and socket joint of the shoulder. And adhesive refers to, well, being sticky. In a healthy shoulder, the glenohumeral joint capsule has a volume of approximately 20 to 30 milliliters, depending on your source. This is also something I learned in prepping for this episode. It's like a partially full water balloon with slack that allows the head of the humerus to move through its range of motion. In adhesive capsulitis, the volume can drop to as little as 5 to 10 milliliters. The balloon shrinks and gets sticky. And when there's no slack in the tissue, there's no movement. I will get into why this happens more in a bit, but more clinically speaking, it begins with synovial inflammation. The synovial lining of the capsule becomes hypervascular or flooded with blood vessels and inflammatory messengers, signaling the body to begin fibrosis. Enter fibroblasts. They differentiate from myofibroblasts, which are the same contractile cells you see in something like Dupuytren's contracture, the condition where the palmar fascia slowly pulls the fingers into flexion. If you know someone who has Dupuytren's, their risk of adhesive capsulitis goes up significantly. Same cellular story, different areas. The result is a capsule packed with type 3 collagen, immature, disorganized, and dense. The coracohumeral ligament then thickens and stiffens, particularly at the rotator interval, the space between the supraspinatus and subscapularis tendons at the front of the joint. Translated into English, the shoulder doesn't freeze, it scars. And it scars around whatever position the tissue has been holding most consistently. The body is not being cruel, it's being efficient. It's doing exactly what my mom used to warn me about, not making my face freeze, but it's making permanent what had been practiced. The loss of range of motion, most commonly external rotation, but often in all directions, is the hallmark of this condition, both active and passive. I've never experienced frozen shoulder myself, but I have seen enough of it in my practice to know that it is both painful and frustrating. So adhesive capsulitis moves through 3 clinical stages. Understanding which stage your client is in will change what you do with your hands and which techniques you will apply. The first stage is called the freezing stage, and it lasts roughly 2 to 9 months. This is the inflammatory phase. So the shoulder hurts a lot, often at night. It's the kind of pain that wakes people up, limits them from lying on their side, and makes taking off a sweater or reaching into the backseat of a car feel like a punishment. Range of motion is beginning to restrict, but pain is the dominant complaint. The shoulder isn't locked yet, but it is in the process of locking. At this stage, aggressive stretching and forced mobilization will make things worse. The tissue is inflamed. You push on inflamed tissue, and it pushes back. Stage 2 is the frozen stage, and it lasts anywhere from 4 to 12 months. Pain has typically leveled off or even decreased at this point, but what remains is stiffness, aggravating, irritating restriction. The capsule is now fibrotic. The joint volume is at a minimum, and range of motion is often near 0. This is the stage where the pattern has been fully adopted and the tissue has, for all intents and purposes, cemented. This is also counterintuitively the stage where clients are the most tolerant of hands-on work because the acute inflammatory fire has dwindled and desperation has set in. Finally, stage 3 is the thawing stage. This stage lasts the longest, anywhere from 5 months to 2 years. The body, left to its own devices, begins to remodel the collagen. Range of motion slowly returns. Most people, not all, but most, recover without surgery. And the timeline is the frustrating part. Patience is pushed to its limits. Also, not everyone gets a clean resolution. Again, in my investigative work, research shows up to 50% of clients still have some residual restriction or discomfort after 3 years, which tracks because patterns that have been held long enough leave marks. That's not a reason to despair, it's just a reason to intervene smartly. Okay, so the big question, who gets this and more importantly, why? The population data on adhesive capsulitis is remarkably consistent. Peak incidence is between 40 and 60 years of age. Women are more commonly affected than men, roughly 58% to 42%, and the condition is bilateral in somewhere between 6 and 30% of cases, though rarely at the same time. But the most important demographic association is a metabolic one. This is where the clinical picture becomes more systemic, where the freeze, if you will, is not just about the shoulder. The prevalence of frozen shoulder in the general population sits around 2 to 5%. In people with diabetes, both type 1 and type 2, that number climbs to somewhere between 10 and 20%. And in poorly controlled diabetes, outcomes are worse and timelines are longer. Why? Because persistent hyperglycemia promotes glycation, simple sugars bonding to proteins. In connective tissue, this accelerates the formation of advanced glycation end products, or AGEs. AGEs promote collagen cross-linking. The fibers lock together, the tissue stiffens, and the capsule becomes less compliant even before the inflammatory process begins. The body at the molecular level has started holding its position early, and the pattern is being reinforced from the inside. So when you have a client with diabetes who presents with shoulder restriction, adhesive capsulitis is on your list of possibilities. Thyroid disorders are also a factor. Both hyper and hypothyroidism have been associated with adhesive capsulitis. The thyroid's role in collagen metabolism and connective tissue regulation appears to be significant, another systemic condition dictating local tissues. Asking if your client has been evaluated narrows down your investigation. And speaking to my demographic, perimenopausal and postmenopausal women are also at risk. Thank you very much. Recent research is growing on this topic. Estrogen, among its many other qualities, has a significant role in collagen synthesis, synovial tissue regulation, and inflammatory modulation. The drop in estrogen during perimenopause may leave synovial tissue more vulnerable to the inflammatory cascade that initiates frozen shoulder. The female incidence of frozen shoulder and this age window line up almost perfectly. That is not a coincidence. The hormonal shift is a pattern change, and the shoulder, it turns out, is paying attention. I've seen this more often in my practice than I want to count. A middle-aged woman with idiopathic shoulder pain and stiffness. I wish I knew then what I know now. And finally, there is immobilization, disuse, and a sedentary lifestyle. Secondary adhesive capsulitis, triggered by a known cause rather than arising idiopathically, is strongly associated with a prolonged immobilization. Post-surgical, post-fracture, anything that keeps the arm still for weeks. This is the most direct version of the mechanism. The tissue is given a position and held there long enough that it then begins to restructure around it. My mom's warning applied literally to connective tissue. A good chunk of my research revealed links from a sedentary lifestyle and low-grade systemic inflammation to frozen shoulder risk. All synovial joints, the shoulder included, need to move to maintain synovial fluid production and capsular mobility. Sit still long enough over enough years, and the tissue adapts to stillness. I frequently quote an ancient proverb that states, "Movement is life, stagnation is death." And here it is, exemplified in shoulders that freeze. If the freeze is the accumulation of stillness, then the argument against it is movement. This is going to be the best case for prevention. I recognize that many of us don't act until it's too late. We have all been guilty of this in one way or another, but this doesn't mean we don't talk about prevention. The glenohumeral joint is the most mobile joint in the body. It sacrifices stability for range of motion. That trade-off means that the capsule, the rotator cuff, and the surrounding soft tissue are in constant negotiation between motion and tension. Synovial joints are dependent on movement for nutrition. The synovial membrane produces fluid that lubricates and nourishes the cartilage, and that fluid exchange is driven by compression and movement. When a joint is immobile, fluid stagnates, tissues become less compliant, and the capsule begins to lose its slack. This is why the post-surgical and sedentary shoulder are at risk. This is why our work, keeping the surrounding musculature elastic and addressing restrictions in the shoulder and thoracic spine, is genuinely preventative care. Movement, passive and active, resisted and unresisted, really is life for a shoulder. When it comes to the actual hands-on application for adhesive capsulitis, the most important judgment is reading the irritability of the tissue. So, noting pain response to touch, movement, and anything else that provokes it. A minimally irritable shoulder can be moved deliberately and recovers quickly. A highly irritable shoulder flares and takes days to settle. In the freezing stage, you'll want to treat irritability like acute inflammation. Gentle, pain-free range of motion, pendulum exercises, soft tissue work in the surrounding musculature, like the upper traps, the levator scapula, the pec minor, and the posterior rotator cuff, Reduce the guarding without provoking the capsule directly. In the frozen stage, your work shifts. Sustained low-load stretching, or a version of proprioceptive neuromuscular facilitation, or PNFs, has the best evidence for improving mobility. The tissue needs time under tension, particularly with a focus on external rotation and abduction. This essentially teaches the tissue that there is more range available than it currently believes. In the thawing stage, the tissue is beginning to revise its position. Your job shifts to restoring neuromuscular control, scapular stability, and rotator cuff strength. This might be a little uncomfortable for massage therapists who lean towards stretching and relaxation work, but shoulders that recover range without recovering motor control are shoulders that will find new compensatory patterns to freeze around. Don't let it form a new habit in place of its old one. To be clear, the joint capsule itself is not directly accessible to massage. We cannot palpate the glenohumeral capsule, and we are not going to mechanically restructure it. What massage can do, and what we do well, is address the surrounding tissue that drives the guarding, limits the range of motion, and reinforces the compensatory patterns. We are not breaking the pattern directly. We are addressing the reasons the body is protecting it. The specifics around any method for bodywork can vary according to your client, but each region has its components that deserve attention. The subscapularis is the primary internal rotator and has a significant capsular attachment. In frozen shoulder, the subscapularis restriction contributes directly to the loss of external rotation. Accessing the subscapularis from the axilla, working along the lateral border of the anterior surface of the scapula with the arm abducted, is one of the most clinical things you can do for a frozen shoulder. Even if your client's shoulder is not capable of abducting, even getting it to move a little bit towards that direction and applying the same technique can do wonders. Working the posterior rotator cuff, the infraspinatus and the teres minor, reduces the compressive load on the posterior capsule and improves the quality of glenohumeral movement. This means sustained compression and pin and stretches to internal rotation. Slow, active motion combined with myofascial glides change the environment. Frozen shoulder is often accompanied by an anteriorly tipped scapula. This changes the resting position of the glenoid fossa, which in turn increases mechanical load on the superior capsule during overhead motion. So, therefore, releasing the pectoralis minor is not a frozen shoulder treatment in isolation, but it is part of restoring the scapulohumeral rhythm that a recovering shoulder needs. It is correcting a postural habit that has been reinforcing the problem. And of course, the shoulder itself doesn't move in isolation. Its movements often require spinal stability or proper engagement of spinal muscles to support what the shoulder is trying to achieve. A disconnect in this relationship can limit or overdrive glenohumeral movement and load the joint capsule in the process. Any work you do to restore thoracic mobility is indirectly improving the soft tissue environment of the glenohumeral joint. Plus, you will often find older patterns that have made themselves at home here. I talk a lot about friction in my work, but there is generalized friction, which is the one I lean more on, and then there is James Cyriak's. He developed a deep friction protocol, which, when applied to the coracohumeral ligament, has some strong evidence of soft tissue release. The technique requires precision in locating the rotator interval, the space just anterior to the acromioclavicular joint, between the supraspinatus and the subscapularis tendons, and applying transverse friction perpendicular to the fiber direction. Don't get overwhelmed by this one. It's a lot to think about, but it can be profound. I don't pull this one out of my toolbox very frequently, but this is a good case for when I would. And finally, it's always a good idea to re-educate the tissues and the client who owns those tissues. Hiking the shoulder up to the ear in an attempt to reach something from a top shelf is almost universal in clients with long-standing frozen shoulder. The upper trap fires, the lower trap and the serratus anterior go quiet, and the scapulohumeral rhythm falls apart. As is often the case with soft tissue dysfunction, a new pattern forms on top of the original one. The body, trying to solve the problem of the freeze, has developed a workaround, and that workaround is becoming its own habit. Your work is to interrupt it. Proprioceptive input, facilitated activation, movement education, and, as always, an empathetic ear. I understand that my mom might have been trying to get me to stop making funny faces with an empty threat, but there were some truths buried in there. The things we hold long enough, the positions, the patterns, the compensations, even the emotions attached to them, those do become structural. Not as punishment, just from the body doing what bodies do, adapting to what it's being asked, and eventually assuming that that's all it will ever be asked. Frozen shoulder is not a dramatic event. It's an accumulation. It's the body making permanent what has been practiced. And nowhere is that more visible, more measurable, and more clinically documented than in the shoulder. It has essentially sacrificed its stability for the privilege of moving in every direction and then forgot how. Movement really is life. And the shoulder, the most mobile joint in the body, the one that made the boldest trade, needs that reminder more than most. Frozen shoulder isn't a death sentence. It's the shoulder asking, finally, loudly enough that we can't ignore it, to be moved again.
Precision Neuromuscular Therapy has been teaching high-quality seminars for over 20 years across the country. Founded by Doug Nelson, PNMT uses problem-solving skills and precise treatment options to get powerful results for your clients. PNMT seminars focus on honing your assessment and palpation skills to precisely target the source of your client's pain while understanding the why behind the what. Meet us in a hands-on seminar or online in the PNMT portal and let us join you on your learning journey. Learn more at pnmt.org. Elevate your bodywork career with Anatomy Train's Structural Integration Certification, ATSI. Discover how to map the pattern and shape the change through inspiring lectures, hands-on body reading, and practical techniques you can use in your practice right away. Join us for ATSI Maine 2026 to 2027, where Tom Myers will personally kick off this transformative professional training. Learn more at anatomytrains.com/ATSI.